Welcome to this explainer. Let's get right into it. Today, we're going to systematically walk through the incredibly high-stakes clinical decision-making required to save a patient's life in an emergency. We're talking about those intense make-or-break moments where literally every single second counts. In these situations, making the correct choice isn't just about having medical knowledge tucked away in your brain, it's about knowing exactly how to sequence that knowledge under immense pressure. Picture yourself in the shoes of an ER doctor for a second. You've just stabilized a critical patient, their vitals are steadying, they're breathing, and that initial panic in the room has finally settled. But here's the multi-million-dollar question. What is the absolute next best step? How do you dodge those plausible, logical-sounding medical traps that could suddenly reverse all of your hard work? Well, that is exactly what we're going to master today by analyzing two highly volatile scenarios. So, here's our game plan for today. We'll start with managing acute anaphylaxis, look at some traps to avoid, then pivot to fluid refractory septic shock, cover the sepsis traps, and finally, wrap it up with the bottom line.
All right, Section 1, Managing Acute Anaphylaxis and Surviving the Aftermath.
Imagine your patient just responded beautifully to an intramuscular epinephrine shot for suspected anaphylaxis. They're stable, they're looking at you, talking in full sentences. You might be really tempted to pat yourself on the back, hand them discharge papers, and send them home. But look at this number on the screen, 20%. Up to a whopping 20% of these seemingly stable patients are going to face a hidden, potentially fatal danger. Because of this, discharging a patient the minute they stabilize from an anaphylactic event is a massive mistake. The crisis isn't actually over, it's just taking a breather.
And that hidden danger, it's called a biphasic reaction. Essentially, the anaphylaxis symptoms come roaring back typically 4 to 8 hours after you thought they were in the clear. Because of this really sneaky window, you absolutely have to keep the patient in a medical setting right next to resuscitation equipment for several hours. You've got to actively reassess them for any symptom recurrence, airway compromise, or hemodynamic instability.
So what's the game plan? Step 1. Keep them in the hospital for observation for a few hours. Step 2. Give them a thorough education on avoiding that trigger allergen. And Step 3. This is critical. Prescribe an epinephrine autoinjector and actually show them how to use it. This strategy is the perfect sweet spot between patient safety and not wasting hospital resources. It sets up a safety net and empowers the patient to handle things if it happens again. Moving right along to Section 2. Anaphylaxis, traps to avoid, navigating those medical myths. Now, it's incredibly tempting to jump straight to long-term care. Sending them to an outpatient allergist sounds like great medicine, right? Well, not right now. Sending a patient home immediately just to see an allergist later entirely bypasses that crucial monitoring window we just talked about. You risk completely missing a life-threatening biphasic reaction. Plus, allergy testing requires a waiting period anyway, since doing it during the acute phase can give you highly inaccurate results. Short-term safety always comes first.
On the flip side of that coin, we have the trap of over-escalation. Jumping straight to an intensive care unit admission for a patient who responded perfectly to a single IM dose of epi and has a normal blood pressure, that is massive overkill. Save the ICU for patients who literally need it, those with persistent hypotension, tricky airways, or those who needed multiple doses of epinephrine to stabilize. Clinical stability means safe outpatient observation.
You also have to watch out for some tricky medication and imaging distractors, corticosteroids, for example. People love to give them, but honestly, the evidence that they prevent these biphasic reactions is remarkably weak. Plus, they take hours to even kick in, and they do absolutely zero to help an acute airway emergency. And what about ordering a CT angiogram to check for a PE? Listen, if it's a clear-cut case of anaphylaxis, hives, swelling, a rapid response to epi, and there's no obvious risk for a blood clot, a CT just blasts your patient with unnecessary radiation and contrast. Don't go hunting for zebras when a horse is standing right in front of you.
All right, let's shift gears to Section 3, Fluid Refractory Septic Shock, the Hemodynamic Crisis. Picture a patient with an overwhelming infection, like a massive soft tissue infection. The infection causes their blood vessels to inappropriately relax. Their blood pressure bottoms out, and suddenly their organs are starving for blood. Your very first move here? Draw blood cultures, start broad-spectrum antibiotics immediately, and pump in a whole lot of isotonic crystalloid fluids. The magic number here is generally around 30 milliliters per kilogram. You're trying aggressively to fill up that dilated vascular system and force the blood pressure back up.
But what if that doesn't work? When you've pushed that massive fluid bolus and the severe hypotension just stubbornly persists, you've officially crossed into fluid refractory septic shock territory. The tank is full of fluid, but the pipes are still way too wide open. At this precise, critical moment, you need a lifeline to actively clamp those vessels down and restore perfusion pressure before the vital organs shut down.
And that lifeline is IV norepinephrine. It's a potent alpha-1 adrenergic agonist, which is basically a fancy way of saying it beautifully restores vascular tone by squeezing the blood vessels. But look at the sequence here. You absolutely have to give the fluids first. Squeezing an empty tank just starves the organs even more. Get the fluids in, then start the norepi, and target a mean arterial pressure, or MAP, of at least 65 millimeters of mercury.
Which brings us to Section 4, sepsis. Traps to avoid. Essentially, don't delay the lifeline.
Just like with anaphylaxis, there are some logical-sounding traps here too. Corticosteroids? Giving them too early is a classic mistake. You only use them if the shock is ignoring both your fluids and your vasopressors like norepinephrine. Giving them right away just risks overusing them for no real benefit. What about insulin infusions? Yes, sepsis spikes blood sugar, but micromanaging glucose is a problem for the ICU later on. Insulin doesn't do a single thing to fix that immediate critical drop in blood pressure. Starting it now just dangerously delays getting your vasopressor running.
Then there are the really dangerous delays that look deceptively logical. Should you wait for an echocardiogram? Nope. If they have a clear infection source, this is distributive shock, not cardiogenic shock. Waiting for an echo just puts off your life-saving pressors. And a blood transfusion? Unless their hemoglobin is critically low, like under 7, or they are actively bleeding, a transfusion just puts them at risk for fluid overload. Remember, their pressure is dropping because their blood vessels are too wide, not because they're bleeding out. Finally, Section 5, the bottom line, prioritizing immediate survival.
The golden thread tying both of these intense, high-stakes scenarios together is the laser-like focus on immediate, short-term physiological stability. Period. Every correct decision is about what the body needs in that exact minute to survive. To recap, with anaphylaxis, once they stabilize, you absolutely cannot just send them packing. Keep them in the ED for a few hours to watch for that biphasic reaction and make sure they walk out the door armed with an EpiPen and the know-how to use it. And for septic shock, you start with fluids and antibiotics, but the absolutely critical takeaway here is that if those fluids don't fix the profound hypotension, IV norepinephrine is your immediate non-negotiable next step. It's the lifeline you need to raise that systemic vascular resistance and save their vital organs from failing.
Ultimately, when the clock is rapidly ticking and a patient's life is literally on the line, you have to look at your treatment plan and ask yourself this one vital question. Are you actively treating the immediate physiological crisis right in front of you, or are you just falling for a plausible medical distraction? Master the physiology, dodge the traps, and you just might save a life. Thanks for joining me on this explainer. Keep learning, keep questioning, and I'll catch you next time.